Good evening, everyone, and welcome to our fall 2024 OI Clinic and Bone Health Town Hall. We're very, very excited to have you with us. That's for sure. As you know, this is part of our effort to ensure that everyone who's participating in the care of individuals with rare bone disease and who host bone health clinics or OI clinics is kept up to date, or as close to up to date as we can help you be. And we're very excited about our speakers for this evening. So let me welcome you. Next slide. And just remind you that we have some additional opportunities coming your way. We very much enjoy hosting the Rare Bone Disease Tele-Echo. And in keeping with our study of rare diseases, we will be doing a deep dive into CODAs in January. Please note that while we normally meet on the first Thursday of the month, that's still January 2nd, too close to the holiday. So we have moved it to January 9th. I hope that doesn't throw off your schedule, but it should be very interesting. This is a specific skeletal problem found in the Amish community and has unique skeletal implications. So we're excited to have Dr. Meyer speak to us. Then also please remember that the OI Foundation has its own Tele-Echo series. They meet on Wednesdays. And so on December 11th, that's next Wednesday, we'll be having a talk on assessing and quantifying pain's impact on quality of life in adults with OI. Next slide. And I would ask for your help. I personally very much enjoy being a member of the OI Foundation and supporting their extraordinary efforts to help the OI community. The levels go anywhere from bronze to silver to gold, and then the 1970 Society. We would be very honored if you would be willing to help support our efforts. Next slide. So we have a busy agenda for today, and so it is my great excitement, really, to have Kenna Coleman speak to you about the many exciting things that the OI Foundation is up to. Kenna.
Thank you, Dr. Tosi. So as Dr. Tosi said, I'm Kenna Coleman. I'm the manager of health education here at the OI Foundation. And I just want to go over quickly some of the resources that either you or your patients may find helpful. So first, each year, the OIF partners with clinics across the country to host a handful of OIF regional conferences. These conferences are one-day events that include sessions and discussions on understanding and living with OI. And these events are great opportunities for both new and longtime OI community members to learn from expert speakers and meet other individuals and families in their area. Some of our past sessions for these events have included medical and orthopedic treatments, pulmonary health, dental health, pain management, mental health, and more. And OI community members also have the opportunity to share their personal experiences and panel discussions. And we do have funding available for the cost of registration for both families and individuals who may need it. So this upcoming year in 2025, we have scheduled Atlanta, Georgia for February 22nd. Denver, Colorado will be May 3rd. And then both Portland, Oregon and Boston, Massachusetts will be in fall of 2025. The next program I want to let you all know about that you may want to share with your patients and their families is the OIF's and the Children's Brittle Bone Foundation's Jeannie Coleman Grant. This grant program offers direct support to individuals and families by providing products or services that will greatly improve their quality of life. Past items have included wheelchairs, orthotics, hearing aids, modified vans, national conference attendance, and more. And the next cycle for the applications will be opening on January 6th of 2025. If you have any questions on this, you can either email Stacy Connors at sconnors@oif.org, or you can also always email bonelink@oif.org, and we can make sure Stacy gets those emails. Next, the OI Foundation recognizes the value of creating a space where members of the OI community can share their personal experiences and both receive and provide support. In the spring of 2024, the OIF launched its OIF Regional Support Group program, and this program is divided into 5 geographic regions with the Northeast, Southeast, Midwest, Southwest, and West. And along with the support of the OIF staff, these are run by 1 or 2 OI community members. And really, these groups aim to provide a space for sharing, educating, and socializing, as well as connecting and fostering a sense of community among members of the OI community within specific regions of the US, and providing national and especially local resources. Information on upcoming meetings and contact information for support group leaders can be found on the OIF's website under the Social Network tab. And then one of the things that the OIF has developed over the years have been comprehensive toolkits to really help both patients and professionals easily access information on OI. So one of those toolkits that we developed and published last year was the Adult Health Toolkit, which is information for adults living with OI, their families, and medical professionals. And this toolkit really provides information on various health topics for adults with OI and contains a range of resources to help them navigate the many aspects of one's health. One of the hopes too with this toolkit is that's a resource that our OI community members who are adults can give to their providers if their provider is not familiar with treating an adult with OI. The other toolkit that's currently published is the Navigating a New Diagnosis, which is a toolkit for parents and medical professionals. And this provides the most up-to-date information on building your prenatal and pediatric care team, navigating the NICU, and looking for information on how to care and what to expect when taking home a baby with OI. And this one also has a section for physicians if they're not familiar with OI. These 2 toolkits are currently available both electronically and in physical copy, and they are available in English, Spanish, and French. And if your clinic is interested in having physical copies, you can email the bonelink@oif.org to let us know, and we will happily send those to your clinic. And I'm also very excited to announce that the OIF is currently developing a new toolkit, which will be a comprehensive toolkit with information and resources specific for school-aged children, their families, teachers, coaches, and caretakers. And topics will include early intervention as well as continued services that a child with OI may need, daycare and aftercare programs, extracurricular activities, navigating the school system such as IEPs, 504 plans, and home or hospital teaching, and age-appropriate language, definitions, and resources for each age group. Like the existing toolkits, the School Age Toolkit will be a comprehensive book that will be available electronically and in print in English, Spanish, and French, and will have information for patients, providers, as well as other team members that may be helping a child during their school years. Next, I want to let you all know about the OI registry if you are not aware of it yet. It is a database for individuals with OI who are interested in participating in OI research and was developed to really help move the research forward by directly connecting researchers with the OI community. Individuals with OI who are either 18 or older, or the parents of or guardians for children with OI, are encouraged to join. And if you have patients, we really encourage you to share this information with them on how to join the OI registry. Once someone is enrolled, they will begin to receive information on upcoming studies as well as online surveys about OI. And they can enroll for that on the OIF's website, and I'll also put a link in the chat after this for that. And lastly, the OIF is currently seeking information on how OI impacts cardiovascular and respiratory issues. The OIF would really appreciate if you could provide information on the cardiologist or pulmonologist that you refer your OI patients, either adults or pediatrics, to. And I'll be providing a link for the survey that we are using to gather this information in both the chat as well as an email that I will send following this meeting. And I just want to thank you all for taking the time to come to this meeting tonight. It really means a lot for us. As I said, I'll send an email out that will have a lot of this information, and it'll also have a survey to provide feedback on these events. Please take the time, if you can, to fill that out. We use the feedback that we get from that and the suggested topics to help build our agenda. So we really want to hear from you all and how best to serve the needs that you have. And now I will turn it back over to Dr. Tosi to talk about transition of care.
Great. Thank you so much, Kenna. And I just want to underscore, we do, in fact, record all of these meetings. And we're hoping that you're sharing these meetings with your staff. This is not just a docs only event or whatever. We really hope that the whole team that's participating in your bone health care will be interested in the topics provided. And we certainly also hope that you will be sure to tell us what we're missing, because we want to keep on doing this and we want to be meeting your needs. So I'm going to talk about my favorite topic for just a minute. I think most of you know I've been in the same spot for 40 years. And like many of you on this call, I suspect, I'm having trouble finding individuals willing to help with the care of my adult patients. And my adult patients are also not used to stepping outside a multidisciplinary clinic. So the problem is all the way around. Next slide, please. So, Kenneth, did you share with me? Do I have the ability to change the slides? I think you will recognize that this isn't just a problem in OI. Adults with childhood onset disorders are absolutely an exploding population out there. I loved it when I found this cartoon. Sometimes, even if I stand in the middle of the room, no one acknowledges me. And certainly I would argue that healthcare generally has its head in the sand when it comes to addressing this growing challenge to the healthcare environment. Next slide. So gut transition has been out there for a long time, and it has 6 very important steps, and it has been a wonderful program for many kids. Next slide. The problem has been that there are virtually no centers prepared to care for folks with rare bone disorders. And so the kids are not having a gentle landing. They're not getting access to care easily, and certainly not quality care. They're not finding people who are knowledgeable about their disorder. So instead of a soft landing, they're basically falling off a cliff. Next slide. Now, interestingly enough, gut transition began to get the message a couple of years ago, and they last spring put out a very powerful white paper that, although not specific to our needs, raised an important flag about, it's not just that we have more patients with rare bone disease, we have tons more young adults with medical complexity transitioning to the adult healthcare environment. So they put out this white paper, next slide, and it focused on critical issues that we mostly can't address. Workforce issues, expanding who's trained, payment policy, education, developing coalitions. Not exactly what we can do, but there's some things we must do. Next slide. So last October, we held a conference called Somewhere to Go. It was originally Nowhere to Go, but we thought that was a little too depressing. So we called it Somewhere to Go. Tracy was on the job there. For adults with childhood onset rare disorders, a conversation about how we can fill gaps in care. And we invited folks from all over the rare disease map. Next slide. We had all kinds of topics: envisioning 21st century centers of excellence, leveraging patient data and experiences, care coordination, developing coalitions and collaboratives. Next slide. And at the end of that, we had a final review and we came up with 21 different actions. And needless to say, we don't have the money and staff to do that. But the top three are something we really are working on addressing. We are working on a landscape analysis that identifies who's doing what we can join up on, what we can leverage, what we can disseminate. And our goal will be to start to develop a rare disease transition resource information center so that if our patients get into trouble, they have easy access to information, both for themselves and for their caregivers. One of the big things that hasn't been done ever is actually developing measures of success. And I'll come back to that in just a minute. And of course, we're always looking at how can we best leverage telemedicine, particularly as we want to be sure that folks with living in remote areas can get the care that they want and need. Next slide. So moving forward, that was last year. And on January 23rd, 2025, we're going to have an all-day meeting particularly focused on this issue of measures of success. It will be a hybrid meeting, and I do hope if you are available and want to participate, we don't have the money to fly you in, but we would love to have you on Zoom and to work with us as we try to come up with measures of success. Next slide. This is a toughie. You know, it's like blind men describing an elephant. We all see the problems differently. Some people want process measures, but there's a lot of data that says process measures don't always mean better health. What would be good health measures? What will be good measures of success, next slide, that work for everybody? We've got a big Venn diagram here. Where's the sweet spot? Where are the opportunities that we could then start to say to anybody working on transition, have you met these standards? How are you measuring up? So we think this is an exciting step forward, and we'll hope that many people on this call will want to participate. And the good Erin is already putting something in, Erica, sorry, is already putting something in the chat. So happy to have you be with us. Next slide. And going forward, what we've come to realize is we can't help all of rare disease. We're only going to focus on our RBDA membership, but that's already 17 organizations with 17 very different sets of problems. So I think this will be an exciting adventure. Next slide. And we are going to be bringing in patients because we feel it is absolutely essential that we include the patient's voice. Finally, next slide. I just want to say thank you. Tracy has been our hero in terms of helping move this forward, as has everybody at the foundation. And this is a great step forward for the Rare Bone Disease Alliance. So thank you. Do I have 1 minute for questions? I think I have exactly 1 minute. If anybody has a question, happy to take them. Don't all scream at once. All righty. Then, if not, then let's move on forward. So I know that one of the truly exciting things from my career has been the improvement in genetic testing. And so it's my great pleasure to introduce Reed Sutton from Texas Children's Hospital, who's going to speak on genetics and genetic testing. Welcome. Glad to have you here, Reed.
Thank you, Laura. Let me... Oh,
You okay? I can't hear you speaking, Reed.
yeah, sorry. I'm just trying to make, I was trying to hide the, are you seeing the panel or no?
No, it looks good.
Okay, fine. Okay. I was like, the control panel was like showing on my thing and I was afraid it was showing on the slides. Okay. So I'm going to talk about genetics and genetic testing this evening. Disclosure, some of the things I'm going to be talking about for genetic testing, our diagnostic lab offers at Baylor Genetics. I do have salary support from Baylor Genetics. Unfortunately, it is not tied to the revenue from the diagnostic labs. But again, we do offer full disclosure, some of the testing that I'm going to be talking about. So I'm going to first talk about basic genetics of OI. I think hopefully most people know this, but just want to be sure that we're all on the same page. I'm then going to talk about the different genetic testing methodologies that we commonly employ and platforms that are used. And then finally, talk a bit about test interpretation. So first, to start with the kind of genetic or molecular basis of osteogenesis imperfecta. So I'm sure everybody on this call knows most OI is due to abnormalities in the synthesis or the processing of type 1 collagen. Type 1 collagen, of course, has two alpha-1 chains shown in blue and one alpha-2 chain shown in green on the slide that form a triple helix that provide structure for bone and other connective tissues. These fibrils that are kind of illustrated here get cross-linked into a macromolecule and then ultimately get calcified to form bone, of course. This is just kind of a schematic representation of how these type 1 collagen triple helical molecules look in normal versus the different clinical forms of OI. So in an individual who does not have OI, this is intending to represent a normal amount and normal structure of type 1 collagen molecules. In most individuals with type 1 OI, and I'll mention this again in a moment, they typically have a normal structure of the type 1 collagen molecules, but the amount is reduced. And then in types 3 and 4 OI, they have typically have structurally abnormal collagen that leads to abnormalities in post-translational modification of OI. And so for people like me who are old, when we used to not have any DNA sequencing and just sent testing for collagen electrophoresis. So this was kind of the basis of diagnosis on collagen electrophoresis. Either you had a normal amount and normal structure of type 1 collagen, you had a decreased amount, but normal electrophoretic mobility on the type 1 collagen testing, or had abnormal electrophoretic mobility due to this abnormal structure of type 1 collagen. Again, hopefully everyone is familiar, but just to be sure we're all on the same page, the majority of individuals with OI, again, have variants in COL1A1 or COL1A2. They can either be inherited from a parent. So in type 1 OI, 50% of the time it is inherited from a parent. In types, but in all types of OI, once an individual has OI, they have a 50% chance of passing it on to their children because of this inheritance. In about 5 to 10% of OI, it is not a COL1A1 or COL1A2 gene change, but rather change in gene that in the vast majority of cases is inherited in an autosomal recessive fashion. So parents are carriers for a change in that gene. They typically are normal and healthy, although in some there could potentially be some risk of low bone density. But then they would have a 25% chance with each pregnancy or each child to have OI. So again, this is just a summary. The type 1 OI, again, the genetic change is typically what's called a stop or stop gain change, which leads to no production of a protein from that gene. Whereas in types 2, 3, and 4 OI, again, these can either be the autosomal dominant COL1A1 or COL1A2, or the recessive forms of OI. And again, the variants in COL1A1 and COL1A2 are most typically glycine substitutions that leads to a kinking of that triple helical molecule of type 1 collagen. But there are other variants that can be seen as well. Next, I'm going to move on to approaches to genetic testing. So again, for old people like me, the kind of original testing, actually, we didn't even have Sanger sequencing for many disorders. We had something called dot blot testing or allele-specific oligonucleotide testing many years ago for certain genetic diseases. And I've mentioned the testing of the collagen protein. But the initial kind of genetic testing for OI was performed by what's called Sanger sequencing. This method involves sequencing one gene at a time, and in the test platform, it can only sequence one strand of the gene at a time. The benefit of Sanger sequencing is that, because you're only sequencing one strand at a time, it is highly accurate in general, although it may not detect an individual who is mosaic for a change because of the small number of bits of DNA or genes that are sequenced. More recently, technology that has been developed and called next generation sequencing is now the current platform for pretty much all genetic testing that is sent. Even if you're only sending off kind of a 1 or 2 gene panel, they often will still do it on a next generation sequencing backbone. The benefit of next generation sequencing is you can actually sequence multiple genes or all genes, which would be exome or genome sequencing, all at once in parallel. You can actually sequence multiple strands in both the forward and reverse direction, which again is because you have many more bits of DNA or many more times that the gene is sequenced. If you have mosaicism, you're going to have a much better ability to detect mosaicism, particularly lower level mosaicism, with next generation sequencing as compared to Sanger sequencing. Although again, because of the large number of genes or DNA fragments that are sequenced, that does make it more prone to an error. So as far as the next generation sequencing, as I'd mentioned, like we often kind of think of it typically as a panel of tests. Usually most labs will kind of have a panel that ranges somewhere between 10 and 300 genes. This typically focuses primarily on coding regions or exons. There's also exome sequencing, and this sequences all coding regions of all 20,000 genes. And then, although many laboratories will often only report out genes that are associated with known diseases, so even though they're sequencing all 20,000 genes, they may not report out genes that are not currently associated with the disease. And then finally, there's genome sequencing. This sequences both the coding regions or exons and the non-coding regions or introns of genes. And this has the benefit of being able to detect things that you cannot detect on exome or panel sequencing. And so things like gene deletions or gene rearrangements can typically be detected by genome sequencing. And so, for example, for people who are familiar with sending chromosome microarray analysis, or also called array CGH, and exome sequencing, genome sequencing essentially can detect changes that are seen on both of those tests, whereas, again, those two tests together, chromosome microarray analysis and exome, are unique in what they're able to detect. My anticipation is that panels are likely to go away, and probably pretty soon. I would say at our institution, particularly for patients that are seen in like our newborn ICU or other things, we often typically go straight to exome or genome sequencing. Part of the reason for that is most labs now often offer rapid testing where you'll get results of either exome or genome sequencing in a few days. And so particularly if you're talking about understanding a diagnosis to guide management or treatment, that obviously having an answer earlier can be helpful. I would say many payers are now covering genome sequencing. And so, for example, in Texas, where I am, Texas Medicaid is now covering genome sequencing. And so I think we are tending now to go a lot more with genome sequencing because, again, we want to be sure that we, provide the best testing for our patients, but also don't close off options. Whereas if we, like, say, for example, started with just a panel of testing, if that for some reason did not provide an answer, it sometimes is harder to get additional testing covered by insurance. And so I think, again, a lot of my colleagues, particularly that see general genetics patients, are now kind of going straight to genome sequencing because, again, it is now covered by certain insurers. And there's always the possibility for reanalysis, which I'll talk about later. As far as the samples and types of samples that we typically use for genetic testing, I think most people are probably very familiar, certainly with blood testing, to start with the postnatal testing. This is done on DNA from the white blood cells that are circulating in the peripheral blood. I think increasingly we now typically use a buccal swab for testing, but really pretty much any type of tissue could be used if one wanted to do so, whether you wanted to do a skin biopsy or a bone specimen. All of those are certainly amenable to postnatal testing. For prenatal testing, the typical testing that has been performed historically, the first would be amniocin testing amniocytes. So this is typically transabdominal procedure to obtain amniotic fluid that's surrounding the baby. And there are cells that float in the amniotic fluid that come from fetal bladder and fetal skin epithelium. And so testing can be done on those cells. That test is typically performed after about 13 weeks of age. Earlier testing can be performed as early as 9 weeks of age on by chorionic villus sampling of placental tissue. This can either be done transvaginally or transabdominally. And again, the benefit is that can be done earlier in pregnancy. More recently, and I'll say more about this on subsequent slides, we can do testing on cell-free fetal DNA that circulates in the maternal bloodstream. So I guess now, probably close to 10 years ago, the technology to test for chromosome abnormalities such as Down syndrome or trisomy 13 or trisomy 18 was developed and was being employed in clinics. And again, this uses cell-free fetal DNA in maternal blood and uses essentially a ratio of the various chromosomes that are detected in order to screen for chromosome abnormalities without invasive testing such as CVS or amniocentesis. Then testing was developed to look for microdeletions or microduplications in cell-free fetal DNA in maternal blood, and then finally single gene sequencing. We've been offering this in our lab for over 5 years now. So basically the technology here, so you see on the far left, the kind of maternal red blood cells that are circulating in these bits of cell-free fetal DNA that are circulating in the blood. You see this DNA molecule here has a little red dot on it that's intended to show a variant in the DNA. And the process in the laboratory is that cell-free fetal DNA gets extracted. The laboratory adds what are called molecular barcodes. So these are tags on the DNA that are detected in the sequencing process that allow for the detection, allow you to determine when you're looking at the results, kind of forward versus reverse sequencing fragments, and also the other aspects of the sequencing. And then, although this process is error prone because of the small amount of fetal DNA that floats in the maternal blood and because of the technology, again, this molecular barcoding allows the laboratory to reduce these various error types shown in red and blue to come up with a result. So for our diagnostic lab, there are other labs that offer this. It needs to be a singleton pregnancy. So if there are twins, obviously you've got fetal DNA from both twins in the blood, which doesn't really work to determine if the twins are discordant. We right now require that there be abnormal ultrasound findings consistent with a particular disorder of interest. The father may have the diagnosis. So even if there's not a fetal ultrasound abnormality, if the father has one of the diagnoses I'll show on a subsequent slide, that would be acceptable. Again, as I mentioned, twin pregnancies, and then if the mother has the disorder because of the challenges in separating maternal versus fetal DNA, we would typically not accept a sample. You can see here there are a number of genes that cause various autosomal dominant conditions included in the panel, including, again, COL1A1 and COL1A2. This is only for autosomal dominant conditions, so we do not test for recessive forms of OI using this test methodology. moving on to kind of how to select testing. So I've mentioned that there's a lot of variability from one lab to another. Certainly most labs on their website have a list of which genes are included in a panel. There are kind of somewhat oddly some labs that have something that's called a panel that only includes call 1A1 and call 1A2, which is essentially the shortest panel you could have. But that's obviously important to know when you're doing testing exactly which genes are on the panel. Some methodologies may have challenges in detecting certain genes. And in certain labs doing non-invasive prenatal testing that I just mentioned, they may not test all coding regions. They may, because of the small amount of fetal DNA, there's a limited amount of what you can do. And so they may only focus on certain coding regions of a gene and not the entire gene. There are things that next generation sequencing, particularly exome or panel based, will miss, such as deep intronic variants. And again, as I'd mentioned, non-invasive prenatal testing may not include all exons of all genes. So if you're going to send that, you need to be sure what they're actually doing. And most labs you can call, if it's not clear on their website, you can call and talk to a genetic counselor or lab director about the testing, and they can help figure out what best to order. As far as testing results go, so about a dozen years or so ago, professional standards were developed from the American College of Medical Genetics and the Association for Molecular Pathology in collaboration to try to harmonize the way all clinical genetics labs across the United States categorized or reported variants in genes. And so these are essentially broken down into pathogenic, where these are clearly established to be disease-causing, likely pathogenic, where there is significant support for disease-causing. And this can come either from prior publications, it can come from population-based data, so ultra-rare variants, or from computational algorithms that can be used to predict whether or not it's likely to cause a gene. Variant of uncertain significance obviously is equivocal, or that where situations where there's really a lack of data about a particular variant, and then likely benign and benign. The important thing to be mindful about is that there often are cases, for example, where I will see, a patient, they clearly have OI, for example, and the variant is categorized as likely pathogenic, but, it's not seen in either parent. They clearly have OI radiographically or clinically. And so, I would not necessarily try to do anything else. However, in cases of particularly of variants of uncertain significance, the laboratory can use the criteria from ACMG and AMP to reclassify variants that can be either family-based data. So if you do testing of family members, either who are affected or unaffected with OI, or if there's some sort of functional testing, and again, if somebody, for example, were to have the type 1 collagen electrophoresis, like we used to do in the old-timey days, that was consistent with OI. Again, those things can be used to reclassify a variant that's seen in one of these genes. And then finally, the laboratories can actually reanalyze data. And so we do this with some frequency, where either the tools or technology improve, or if there are new genes discovered for a particular condition that were not known before the testing was done in the first place, labs can reanalyze data and can, again, if there are findings, can reissue a new report. So again, just to summarize quickly, most OI is dominant and due to call 1A1 or call 1A2. Newer genetic technologies can sequence many more genes, including recessive genes of OI. I think even though most of us probably are sending panels, I think in the near future, moving to exome or ideally genome is going to be the best for everyone. I talked about non-invasive prenatal testing using cell-free fetal DNA in maternal blood and how that can inform management. And, emphasizing, I think most labs are generally very good about getting on the phone or emailing if either kind of you're unsure what testing options would be the best for a patient, or if you're unsure about results or about reanalyzing or reclassifying variants. So I will stop there. And if there is time or if there are any questions, I'm happy to take them.
Terrific. Thank you. So what we have on our schedule right now is to just take a deep breath and make sure that any questions that are out there are answered. And we're a small enough group. I think people want to raise their hands or want to put something in the chat, or really just speak up for the moment. And so I just want to be sure I get it right, that you're not going with anything big if the baby looks like they have OI.
Yeah, I think, well, I guess I would say it kind of depends upon what the clinical situation is. So I think if it's, an infant in the newborn nursery or newborn ICU who's otherwise stable and generally doing pretty well, I think probably we would mostly just send a panel test. However, if it looks like a type 2 or type 3 OI, there are a lot of medical issues. Again, I think and I would say, like, I'm telling you, I don't see these patients. They go first to our general genetics team, but they would typically send a rapid trio exome or a rapid trio genome, just because you're going to get results back in a couple of days. And, if you're thinking about, what level of support is indicated, what therapeutic options should we be pursuing, that's something that, again, you're going to get that back very quickly. So I think I would say that a lot of times, particularly the ones that are in the NICU at our institution, they typically tend to either get a rapid genome or a rapid exome.
So then an unfair question, really, I'll be honest.
Sure.
So what's shown up in my bone health clinic of late are more and more non-accidental trauma kids. And I actually have one kid where I'm absolutely sure there's an underlying diagnosis. But the father's about to go to prison because no one's been able to define it. Kid's got odd frontal bossing, weird x-rays, et cetera, et cetera. But some of the courts around here don't seem to care. And my saying we just haven't found the gene yet isn't enough. What is your favorite genetic testing in a case like that?
Yeah, I think that's another case where that's a great example where genome sequencing would offer a lot more than the kind of standard tests that I think most people currently do. So I'll give you an example. So I have a patient with type 6 OI who literally he had kind of everything done. We were not able to identify, any sort of cause. We enrolled him. This is like 6 or 7 years ago or so ago now. So genome sequencing was not available clinically. We enrolled him in our undiagnosed diseases network, and he has a deep intronic homozygous variant causing type 6 OI that, again, is just because of the way the technology works for either the panel or an exome test, that you just can't detect it. It's just not included in kind of what's captured on the panel or the exome. So, I mean, I think that that's why, again, I really feel like that at some point we all ought to just bite the bullet and move to genome sequencing and call it a day, because I mean, there are limitations for these things, and particularly if it's something that insurance is going to cover. I mean, I think that, you know, 'cause again, like you said, I think we all want to provide the best care for our patients, right? While certainly we want to be good stewards of our medical resources, which we all know are limited. But, you know, I think a lot of these cases, providing the best care is, you know, should be our primary obligation for our patients.
Here, here. All righty. Let me just be sure. Good. Okay, we do have some folks in the chat. All right. Thanks, Erin. All right, so Pam Smith asks, do you have any recommendation if the child has a mild presentation but results with heterozygous variant of unknown significance in a known OI gene P3H1? Should present severe if homozygous. These situations come up at times.
Yeah, I think there are kind of a couple of options there. One certainly would be to test parents if that's not done. I think that, you know, if you can find a researcher who would be willing to do functional studies, that would be another option. So again, that can often lead to variant reclassification, where again, you know, if there's a kind of an established function, what we would call like a functional test that could be done to look at, you know, either kind of prolyl 3 hydroxylation of type 1 collagen or other sorts of things, that again would be a case in which you could kind of take that and say, look, go back to the lab that did the test initially, look, here's the functional test that we have, and then they can reclassify a variant.
Great. Well, I'm going to try to keep us on time. Thank you very much. One has to hold on with one's fingernails, keeping up with what you genetics guys are doing. All righty, but you're still on the hot seat. And so now we're going to move to your second talk. And very important, summary of new medication trials for OI. Eager to hear what you've got to tell us.
Yes, where's my share screen? I've got too many things going on my computer here. I'm sorry, I'm trying to share my screen again. Okay. I think everyone can see that okay?
Yes.
Okay.
Yes.
Yes, we're
So,
great.
so this one is not quite as complicated as the previous talk. Hopefully everybody will be happy about that. So I'm going to talk about clinical trials and drug treatments. We're going to talk again mainly about the anti-TGF-beta antibody therapy treatment for OI, and then talk about anti-sclerostin antibody treatments for OI. Again, one of the things that we know, obviously, in OI, that there's increased osteoclastic activity and increased bone turnover, that results in increased TGF-beta signaling that has a series of cascade effects on fibroblast growth factor 23 or FGF23, on sclerostin, which again, as you see over here, mediates osteoblast, has an inhibitory effect on osteoblastic activity, and then again, kind of through these secondary effects of parathyroid hormone on both osteoblasts and osteoclasts. So as part of our brittle bone diseases consortium that a number of you are partners in, a few years ago, we obtained an anti-TGF beta antibody, fresolimumab, from Sanofi. This had initially been developed for a cancer indication, but for a variety of reasons, they did not pursue that, but they provided it to the BBDC for free to perform phase 1 clinical trial of this anti-TGF beta antibody. This is based upon mouse work from Brendan Lee, Roy Morello, and others' labs showing increased TGF beta signaling in both recessive and type 1 collagen forms of OI in mice, and that treatment with anti-TGF beta antibody in those various mouse models of OI could result not only in improvement in bone, but improvement in lung architecture and other issues. And so because of that, we performed a study led by Sandesh Nagamani to look at this anti-TGF beta antibody fresolimumab in a phase 1 clinical trial. So individuals just got a single dose. This was a relatively short-acting treatment, and they were followed by 6 months of observation. This is on the panel over on the left from Sandesh and Ewen. This is just showing bone biopsies and changes that are seen with treatment. Over on the right in these panels here, you see the individuals with type 3, 4, and 8 OI and the percent change in lumbar spine bone mineral density after this single dose of fresolimumab at either the kind of 1 milligram dose shown here. Either the 1 milligram dose that's shown here, or in the 4 milligram dose that's shown over here. And so you kind of see, again, this is one dose. So again, these individuals kind of went up, but then unsurprisingly, they're going to go back down again because they're only getting one dose. Sanofi went on to develop a longer acting form of an anti-TGF beta antibody and performed a phase 1 clinical trial called the POISE-1 trial. This was done in the US as well as Canada, France, and Australia. There were 24 individuals that were enrolled, and they were, again, as any phase 1 clinical trial, looking primarily at safety, but also looking at bone biomarkers, DEXA, and other indicators of bone density. Unfortunately, Sanofi recently announced that they did not achieve the clinical endpoints they were hoping to, and were not going to pursue this anti-sclerostin antibody further at this point. Again, I know a number of individuals on the call today are investigators, and I think there's some Ultragenyx folks on the trial as well that are very familiar with this. So there was this study called Asteroid of an anti-sclerostin antibody. This product was obtained by Mereo from Novartis, and they performed a phase 2b study in adults with OI. You can see the clinical trial design here, and individuals were randomized to either placebo or escalating doses of sestrusumab, the anti-sclerostin antibody, and then individuals after the 12 months of treatment with the monthly infusions of sestrusumab could opt for consolidation with zoledronic acid, and then they assessed initially, the primary endpoint was high-resolution peripheral computed tomography, HRP-QCT, but they also looked at aerial bone mineral density biomarkers and other things in the study. So what was seen in the Asteroid clinical trial is that both at the highest dose shown in purple, got the best increase in bone mineral density at both the lumbar spine and the radius, and you saw a decrease in serum CTX, as well as an increase in serum P1NP with the cestrusimab treatment. They went on to partner with Ultragenyx to perform phase 2/3 continuous clinical trial in children. And the first bit of data from the phase 2 study that is called Orbit has been published. Orbit is a randomized double-blind placebo-controlled phase 2/3 seamless study of cestrusimab. Again, this fully humanized anti-sclerostin antibody, and it's in individuals with types 1, 3, and 4 OI. And again, that's kind of the call 1A1 and call 1A2 type call OI. Individuals can be between 5 and 25 years of age. There were 24 individuals in the phase 2 trial, and then in the total phase 3 trials of both Orbit and Cosmic, there'll be, I think, 219. As a quick summary, again, because I don't have a ton of time to talk about this tonight, what was seen at the 6 months in the phase 2 study was a 14% increase in lumbar spine aerial bone mineral density, and then at 12 months, a 22% increase in lumbar spine bone mineral density. Obviously, these many of these are growing children, and so they also looked, which one might expect they would increase their BMD just because of increased growth. And so they looked at the Z-score change as well at the lumbar spine, and there was a mean baseline, the mean baseline lumbar spine bone mineral density in that group of 24 individuals, and I should say there was a relative preponderance of type 1 OI in here, went from -1.73 to -0.49 across all age groups and all types, although again, the most commonly type 1 OI. In addition, the primary endpoint of the phase 3 clinical trial is going to be fracture rate. And so that was assessed in the phase 2 study as well. And of those 24 individuals, they had an average of 16 months on study. And the annualized fracture rate for the Orbit phase 2 study showed that there was a 67% or nearly 2/3 reduction in annualized fracture rate. Although again, I should be clear that again, there are some individuals that the mean was 16 months. And so again, there is some calculation done there. The other caveat is that there was a requirement for fracture as a enrollment criteria in the clinical trial. And so there are, again, kind of the phase 3 studies of cestrusimab I'd alluded to earlier. There is the Orbit phase 3 study. This is, again, still a randomized double-blind placebo-controlled trial, the same age range and the same OI type. Enrollment in that trial has been completed. And then there's Cosmic. So this is a trial in younger individuals. It is randomized, but it is an unblinded trial of cestrusimab compared with bisphosphonate standard of care. And so that's up to the discretion of the principal investigator. This is, again, kind of the same OI types and either type call 1A1 or call 1A2 related OI. It'll be 66 individuals, and it's individuals from 2 to 6 years of age, and enrollment is also completed for the Cosmic trial. And then finally, there is a trial of romosozumab. This is also an anti-sclerostin antibody. The brand name of this is Avinity. It is approved by the U.S. Food and Drug Administration for postmenopausal osteoporosis. It is a monthly subcutaneous injection. And they recently, Amgen, who produces romosozumab, recently launched a phase 3 clinical trial. It is open label and randomized, and it will be a comparison of romosozumab with bisphosphonates in children and adolescents. They will be enrolling, got that in a weird place. They will be enrolling 106 individuals primarily in Europe and North America. Enrollment only began in April, and I think the first patient in was in Central or Eastern Europe. And so this is kind of very early for the romosozumab trial. Their primary endpoint is also going to be fractures at 12 months of treatment. They will be looking at lumbar spine bone mineral density as well, in addition to other secondary endpoints. So I will stop there, and I'm happy to take any questions.
I think an unfair question, but I think the question that always comes up is, and I realize you're not an endocrinologist, but what, for the adult who's fracturing, do you have a favorite drug at this point?
Yeah, I guess I think that I think to some degree, well, certainly I think, let me first make the distinction of, there are certain forms, particularly of recessive OI, where they have a low bone turnover phenotype. So actually, the patient I'd mentioned earlier with type 6 OI that had deep intronic, he's caused me all sorts of challenges. And not only could we not find his variant, but then once we found his variant, type 6 is a low bone turnover form of OI. So that explained why, despite my slogging away with bisphosphonates with him, that he never got his bone mineral density any better. And so, in those forms of OI, bisphosphonate is not going to work. So after a lot of work on me and my clinic staff, was able to get insurance to agree to approve him for a year of romosozumab. I do think for it, probably for adults with OI, that romosozumab, particularly because they have relatively adynamic bone, that's probably going to work better. I would say it was really challenging. It took almost a year for me to, with multiple back and forth with the insurance and peer reviews and other things, to get romosozumab approved. So I think that's probably the best option, but it's a lot of work. Teriparatide, again, in the OI clinical trial, it really only works for type 1 OI. It does not work well for types 3 or 4 OI. So that's really not, that would be maybe an option for a type 1 that's having some fractures. But again, if it's kind of the type 3 or 4 that are having a lot of fractures, that teriparatide is also not really going to be a good option.
Unfortunately. It'll be very interesting to watch these trials and see how our kids do. That's for sure. All righty. So I'm a minute or two behind here, but I want to be sure that, no, you're doing great. But I just want to be sure everyone's asked their questions. Please pop up, speak up. If you're chewing on something that you just want to spit out.
Or I'm happy to reply in the chat. I'll try to watch the chat. And so
Great.
if we've got time issues, I'm happy to chat reply.
Great. Well, thank you so very, very much. Great set of talks, and boy, are things changing. That's wonderful. All righty. Then I would like to move on to understanding and treating chronic pain. And I want to welcome Christopher Joseph from Kennedy Krieger Institute. Thank you so much for being with us, Chris.
Let me see here. Can you guys hear me?
Yes, we can.
Okay. How do my slides look? I'm going to share my slideshow. Okay, everybody see my slides there?
They look great.
Thank you. So I'm Christopher Jones. I'm the director of physical therapy for Kennedy Krieger, and I work in the pediatric connective tissue clinic, but I also see adults with osteogenesis imperfecta. I also work in the pain clinic at Kennedy Krieger, so I have a lot of experience with pain. So I'm going to speak to you today about the physical therapy side of treatment with for pain with osteogenesis imperfecta. So I have nothing to disclose. So our objectives today are to talk about the clinical presentation of pain with OI, osteogenesis imperfecta, an overview of some of the research and clinical experience we have at Kennedy associated with OI, and to understand some of the pain treatment associated with OI, especially from a physical and focus from a physical therapy perspective. So some of the leading causes of pain in patients with OI are a recent fracture, bone deformity, muscle weakness. They have impaired muscle, cell and muscle signaling, low muscle tone, joint laxity and instability, weakness of ligaments, and of course, age-related changes. We're going to start off by talking a little bit about deformity. So from our clinical experience, my clinical experience, from deformity, patients with OI get an abnormal stretch on their muscle. They have increased stiffness. They have also abnormal stretches on their ligaments, which, and increased stiffness as well. And they have impaired connection between their brain and the muscle. The proprioceptive input they're getting is different because of the bone deformity. So when we talk about muscle weakness, we know that people with OI have a lower endodermal force production. This is evident through OI type 1 OI mice. There's impaired muscle endurance and a decreased number of type 1 fibers in people with OI. They have a higher weakness in response to injury. What I mean by this is generally these patients, if they do injure a muscle, their weakness occurs instantaneously. And sometimes we even mistake it as physical therapists for a fracture. They have more stiffness reported in their muscles in general. And the presence of pain can be, again, perceived as a fracture in some of these patients when the muscle's injured. They also have, again, we talked about this abnormal signaling to the muscle and imbalance in the muscle. So all can cause muscle weakness. So the next thing we'll chat here about is a joint laxity and low muscle tone, which is evident in adults and children with OI. Some of the research and clinical experience around this, we have, again, increased pain signaling. If a joint is out of place or the tone is a little lower, the signaling from the proprioceptive organs aren't working as effectively, so this could be perceived, or the brain could perceive this as OI. There's increased stress on the joints and the muscles in adults and children with OI because of their condition. This can lead to injury to either the ligaments, muscles, and bones. And then again, we talked about the abnormal signaling occurs due to the muscle imbalance that, again, it all interplays with itself, most of this stuff together. So let's talk a little bit about the impaired positioning and signaling. Children and adults with OI generally have poor body biomechanical mechanisms going on. Sorry, distracted there. Have bone deformity, and these abnormal biomechanics are usually from bone deformity and contracture. They can also be from just short stature and just generalized decreased bone growth in general. This causes a lot of impaired signaling from the muscle tendon organs, as well as the tendon organs and the joints. And this abnormal signaling, it doesn't feel well for these patients, so it's perceived as pain. Can be perceived as pain. Not advancing. Here we go. So Reed talked a little bit about some of the TGF beta signaling, which from a physical therapy perspective, after reading up on this, I'm really excited about this coming out, but it's kind of, the fact they stopped the study is a little let me down a little bit. But the patients with OI have this abnormal signaling, and we understand a little bit from some of the research that there's an abnormal relationship with fibrosis and inflammation that occurs. So this extra signaling can cause fibrosis and inflammation in the muscle by some of the evidence that's out there. So let's talk a little bit about age. That was one of the factors we talked about in our beginning there. Muscle injury occurs more and fractures in adolescence. Occurs more than fracture in adolescence. These children are going through puberty. The hormones are starting to start up. So, we see less fractures and more muscle injury in these patients. These muscle injuries can feel like fractures and can be just as debilitating as fractures. So, that's why, treating a muscle is important as well as a bone with an adult or child with OI. And this can cause, again, with these adolescents with OI, inactivity, which can cause injury and pain further. There's a vicious cycle where there's inactivity, there's pain, there's more inactivity, and then that leads to more pain and stiffness. So breaking this vicious cycle of pain and inactivity is important with children, both children and adults with OI. So adults with OI, we see, some osteoarthritis, which starts in the early 20s and 30s. This can significantly impact joint mobility, can also impact joint signaling, with, from the again to the brain. And in generally with adults with OI, more pain is reported by the patients in mild OI than severe OI. This is from our self-reported clinical experience, and we see this also in the literature where your patients with the same level of OI, the walking patients generally report more pain than the non-walking patients. So hypermobility can also lead to pain in adults with OI. Poor alignment can lead to added stress on the muscles and joints. You can get an overstretched muscle, which can be injured, as well as get some abdominal signaling from that. This pain could also, again, lead to sedentary behavior, loss of range of motion, and ultimately loss of function. So staying active is really important for an adult with OI. So some of the natural history information that we participate in the study for the Rare Disease Network. We generally see that pain begins in adolescence. Again, it's reported more with higher functioning adults and children. We have it's a significant factor for adults. We also see that some of the 6-minute walk data shows us that fatigue increases the age. This fatigue can lead to immobility and pain. So improving this with exercise is really important. So I'm going to chat. I know the next speaker is going to talk to you a lot about biopsychosocial model of pain, but it's really important in the treatment of pain in both adults and children with OI. We see here biology, psychology, and somebody's social environment is really important in pain. And then when we talk about biology, we talk about, of course, genetics. And then the things here with PT after them is all the things us as physical therapists can contribute to. The neurochemistry, some of those there's joint signaling activities that occur, that I mentioned before. Medications are important for biology. Motor functioning, again, the PT can impact this. Muscle strength and biomechanics and age-related changes are all things about biology that happen. Psychology, we all know that stress, anxiety, mood, memory, and beliefs can all impact pain level. The sympathetic and parasympathetic systems, that associated with pain are also associated with stress and anxiety and mood. So these mechanisms work together, to increase pain. So it's important to actually treat these factors. And then there's social factors that all impact pain, right? Family factors, the environment somebody lives in, their social support groups, their interpersonal style, their culture and beliefs, and their socioeconomic status is all important, when you're treating a patient with chronic pain. So now, as a physical therapist, I'm going to chat with you about treatment for adults and children with OI. We like to work across the aisle with all disciplines. Sometimes we'll pair psychology with physical and occupational therapy, understanding the relaxation techniques, cognitive behavioral therapy. They're all important to happen. Those techniques must happen during the treatment with physical therapy to really work on that pain. We try to time our medication. We really want to time medication so that it's happening during the therapy sessions, so that we can actually, get the maximum benefit out of the pain treatment. And when we talk about medication, talk about more like your NSAIDs and your long-term, medications that affect pain. So, and then we work like with genetics and endocrinology and orthopedics, because they could all help us, treat with the treatment of patients with osteogenesis imperfecta and pain. So some of the goals about pain in OI is to improve function, of course, improve muscle strength, reduce fatigue. Yeah, as you can see, decreased pain is down the bottom towards the list, because that doesn't usually always happen right away. Sometimes you have to improve function, muscle strength, and fatigue first before you get that decrease in pain. So it's really important to express that and let the patients know that when you start your treatment. Fracture prevention through treatment of muscle weakness is important. We want to improve muscle strength and signaling, and we want to prevent further deformity. So some of the orthopedic considerations, that we do with patients with OI, and as age OA becomes worse, it's important to treat some of that OA with exercise and activity. We, as physical therapists, know we can have a positive effect on osteoarthritis. But joint replacement is not totally out of the question. We do have some patients that have joint replacements that have done really well with joint replacement, even though they have OI. So it's important to consult your orthopedic doctor as well when you're treating, especially an adult with OI who's having these OA changes. In the treatment of pain and OI from the physical therapy standpoint, I'm really going to work on balance, protection with mobility. I want to work on joint stabilization. I want to stay within that range of motion, right? We don't want to do too much hyperextension or a limit range of motion. We want to stay there. We want to avoid immobilization, because this can lead to fracture, pain, and further dysfunction. We talked about this cycle of pain and immobility, and we really want to break that cycle and add mobilization and add mobility to improve pain. So it's important to know that muscles are shock absorbers, right? They reduce stress on the bone, and it's really important to treat the muscle to help strengthen and protect the bone. We want to maintain joint alignment during physical therapy. Leg length differences are really important and significant, especially in older adults and adolescents. Generally, younger children, can if it's a mild change, doesn't have to be treated like this different way. But as you get older with an adult and a adolescence with a leg length change, you want to treat this with some kind of lift or something like that. I believe in minimal bracing. I really want to focus on strength and control first and have them learn to control their body. I feel braces kind of limit range of motion as well as can contribute to further weakness. So let me start at the bottom and work our way up the leg in order as far as bracing and work on minimal bracing. So we talked about joint stability and strength. This also reduces stress on the tendons and joints, because a balanced, strong muscle can protect the tendon and protect itself as well. We want to balance alignment with freedom of movement, right? We don't want to limit their activity because we want to prevent injury and improve joint and muscle signaling, right? If we have a balanced, strong muscle, it's going to send the proper proprioceptive signals to the brain. When we talk about strengthening for adults and children with OI, we really want to distribute the weight over the bone. We don't want to create long lever arms. We don't want to, add resistance even during our muscle testing at the very end of the bone, to cause that stress. We want to, have that stress or that resistance more proximal. We want to avoid substitution, right? And a lot of times when even regular adults who have weakness, they substitute and add muscles in to help them do an activity. This can be detrimental for a patient with OI. The big example I use is hip extension. Everybody ignores their glutes. The glutes is the weakest muscle in every person, probably in the presentation listening today. And one of the substitutions we do for the glute weakness is we push, for laying and prone with one knee bent up, we actually push down with the opposite leg to lift, the one leg up we're trying to get off the ground. With an adult with OI or an adolescent or child, when they're pushing down with the opposite leg, that can cause a fracture on the opposite side. So we want to reduce that substitution and work on protection and joint protection. And again, we talked about proximal pressure. We really want to reduce the risk of fracture and do proximal pressure more than we want to do distal pressure for strengthening. Some little things about strengthening, we try to avoid bridging because it can lead to torque on the tibias. So this is an exercise we try to avoid with adults, children with OI. We want to work on stability and control, not so much mobility and speed. So you're going to walk slow and control with your strengthening. And again, we want to maintain proper alignment and range of motion when we're strengthening. So, versus doing a knee extension exercise, pushing out against the bottom of the ankle, you might want to do a squat instead, where you're distributing that weight down the long axis of the tibia. We talked about reducing lever arms, reducing force. Another thing to be aware of is that fatigue can lead to further fracture. So when you're strengthening somebody, you really want to balance endurance training. You work on pacing with strengthening and cardiovascular activity. Because if you start exercising too much, then that muscle gets even weaker and fatigue. The patient gets out of alignment. You can increase the risk of fracture during this activity. So we really want to work on balancing that fatigue and pacing activities when we're strengthening. And I put in here the OI guide for physical therapy for people to see, and you can also get it through the OI Foundation. So what we know that muscle mobility and just movement in general loosens muscles. It reduces spasms. It improves blood flow. It helps increase lubrication of the muscles and tendons and joints. It also reduces inflammation as well. So it's really important to stay mobile when you're with patients with OI. It improves joint signal. We talked about this already. If an improper proprioceptive signal is being sent to the brain, this could be perceived as pain. So improving muscle strength and muscle and joint range of motion can really impact muscle signaling. We also know that it impacts brain chemistry, right? So strengthening and releases endorphins and increases dopamine, and it helps with regulation, right? How many people out there really feel better when they exercise because they're really regulating themselves? I kind of relate this to having a baby who is all upset and you're swaddling them with a blanket and you're squishing them, hugging them. They really feel regulated in that position. Exercise can be a regulating activity for most people, so it can really help regulate people who are oversensitive and hypersensitive to pain. And here are some of the modalities that we can look at when we're talking about treatment of pain with adults and children with OI. Aquatics is really good. It spreads the weight along the length of the bone, so it's not all focused in one area. It reduces gravity. It also offers velocity-dependent resistance, right? The faster you go, the more resistance you are. So you can really offer some, you can control the amount of resistance that's happening in the pool. It also has the therapeutic effect for heat, right? My patients with OI tell me they really like and enjoy a warm pool, so that they really enjoy the benefit effects of heat. Neuromuscular extrastimulation is another technique that I use for treatment of adults and children with OI. If we get that muscle pumping, we can reduce some of the inflammation. It also assists with strengthening. TENS can be used not only as a pain reducer, so we apply that TENS to the area that hurts and turn the TENS unit on, but it also can cause relaxation in the muscle. It shows that it can impact dystonia in children and adults with brain injury. And I've had some clinical success with using a TENS unit on a muscle I'm trying to stretch to lengthen that muscle when it's contracted and help it get more range of motion. So it's considered TENS when you're also treating patients, adults with OI with muscle tightness and pain. Functional electrical stimulation during movement can also help, that muscle retraining or that body retraining, if they're not moving appropriately during the education activities or during the physical activities, you can use the eStim or the FES to help them properly time and fire their muscles during activity. So it's really important to get that muscle signaling up to the brain. So last thing on my list to talk about here is that, when all else fails, we do intensive rehab for some adults and children with osteogenesis imperfecta and have pain. It's typically a multidisciplinary approach to treatment. It's got OT, psychiatry, psychology, occupational therapy, physical therapy all together. The goals in general are to increase mobility, increase mobility and function with reduction of pain. That the patients learn pain coping strategies in with the physical therapy session, and the activity sessions they learn pacing and endurance building. These are all important things to learn when you're an OI patient with chronic pain. So some of the outcomes again that we get from the intensive rehab are increased function, improved mental health, and improve pacing and improve endurance. And of course, the last thing on the list is decrease in pain. And like I said before, the functional and the mental health and endurance changes happens first before generally we see that reduction in pain. So here are my references. I think I caught us up, Dr. Tosi. Thank you. Anybody have any questions? I saw there were 2 questions in the chat. Let's see. Doesn't look like it's, the OI guides. Thank you, Erica, for putting the OI guide in there. Anybody have any questions for physical therapy and treatment of chronic pain?
Thanks, Chris. That was a great talk. We're going to have a little bit of time for questions right at the end, too. We're going to move right on to our next speaker, Dr. Ricky Carroll. He's signing off.
Sorry, I'm talking away, Erica, with my microphone turned off. Thank you for the rescue. Yes, please keep on going.
But we will have some.
But actually, talk about what you put in the chat, though.
Sure. So I've added in the chat there just a link to the LIS PT guide that Chris mentioned during his talk. Again, all of these resources are available electronically and also in print. So if you'd like a print copy for your clinic, just send us an email. We'll get those to you. We're going
And
to
in
move
the
on.
past, yeah, I was gonna say, in the past, that guide has only been pediatrics, but now there's an adult section too. So be aware that if you have adult patients with OI, to refer to that section as well.
Absolutely. Thank you. All right, we're moving on right now to Dr. Carroll, who's joining us from Amsterdam in the middle of the night. Thank you. And your slides look great.
Okay, cool. Can you hear me, Erica?
Yep, sounds good.
Okay, awesome. Hi, everyone. My name is Ricky Carroll. I'm a chronic or a complex care and palliative care doctor. I'm trained in palliative care. I'm on the OI team at Nemours in Wilmington, Delaware. And today I'm going to talk about chronic pain, which is something I'm passionate about, near and dear to my heart, that I have training in through my palliative care experience. And something that, of course, we see a ton of with our young adults with OI. And these are my disclosures, and also wanted to mention that all the photos in this presentation are patients of ours that granted us permission to use them today. I'm going to briefly touch on the fact that pain in OI is common, which Chris already talked about, and we all know well. Kind of go through what is chronic pain in OI, and then most importantly, go through my approach to chronic pain in OI. So we all, we've heard it and we all know it. Chronic pain is common. But, some interesting points about chronic pain in specifically OI is that daily pain is reported in a majority of individuals with OI, and it starts young. So there's like a, high percentage of children and teenagers who report chronic pain, and that high percentage continues into adulthood. And then, even into, your older population, 60s, 70s, 80s as well, of course. You would imagine that the rate of fractures would correlate with pain, but it's really not the full story, because, the percentage of people who have chronic pain is pretty similar in those with less than 10 fractures up to those with fractures in the mid-30s. So we know that number of fractures really isn't the whole story. And some of the results from BBDC also support this. So 62% of people with OI reported pain, and prevalence of chronic pain did not vary across OI types. So there was chronic pain seen in all the types of OI. And there was kind of this indication that bisphosphonates may correlate with reduced pain. And then similarly in 2022, a big, cross-sectional study looking at chronic pain and found the same thing, that there was, a correlation. There wasn't a correlation between OI type and frequency of OI and frequency of pain. Sorry. So, when we talk about chronic pain in OI, what is chronic pain? The most common definition being pain that persists or recurs for longer than 3 months. But then, the other kind of helpful definition is longstanding pain that persists beyond the usual recovery period or occurs alongside a chronic health condition. And so, what is chronic pain? It can be a lot of different things. It can be bone pain. It can also be joint pain, joint stiffness, muscle spasm or muscle cramping, muscle fatigue, nerve pain, whole body pain, whole body fatigue, or can be kind of complex and involve multiple systems. And then what do we mean when we say chronic pain in OI? It can, of course, be fracture pain, but typically it's fracture pain that we're thinking that persists beyond your usual recovery period. It can be post-op pain that persists beyond expected recovery period. frequent or recurrent bone pain, compression fractures, and spine curvature leading to chronic or continuous back pain, musculoskeletal pain, neuropathic pain, body fatigue, and kind of the list goes on. And so why does it happen? You know, I think Chris did an awesome job of talking about this, but this is what I tell families. This is how I talk to families about chronic pain. I say, you know, you started with pain from an incident, from a cause. It might have been a fracture, it might have been post-operative, you know, a surgery, or could have been anything. And that leads to muscle tension, which leads to pressure on the nerves, reducing circulation, leading to muscle shortening, which restricts movement, which affects your sleep, which causes sadness and worry about your pain, which causes more pain. And it just kind of feeds into this cycle of pain. The other way that I talk to patients and families about their chronic pain is kind of the sticky nerve theory, which is that your nerves get really good at sending pain signals the more that they do it. So similar to when you're learning how to knit, when you first learn how to knit, you're watching every stitch really closely. But then, you know, when you get really good at knitting, you can kind of do it while looking around and really not focusing on it. It's almost second nature to you. And that kind of happens with nerves too. When your nerves are constantly sending pain signals, they get really good at sending pain signals, and they can get stuck in that cycle and really sensitive to that, to any kind of stimuli, because they're so good at sending those signals. And so what I talk to families about is kind of that we need to retrain their nervous system, retrain their nerves, and tell their nerves to calm down. But how do we do that? So I talk to families about the pain dial. So right now their pain dial is dialed in really high, and we need to figure out how to dial down the pain. And the reason why I use the dial is because I tell them we're not going to bring your pain down to a 0, and that's not really the goal. The goal is to dial down the pain to a level that's functionable and sustainable, and that you're able to live through it. And the other thing is that we need to dial down the pain by using multiple different modalities. So it's not just going to be one thing that dials down the pain. We're going to do 4 different things, and each thing is going to click, 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 dial down the pain. And, you know, of course, we want to excuse me, go back to our OI basics. Of course, orthopedic evaluations as appropriate. Of course, address bone mineral density, optimize your vitamin D, think about pamidronate, etc. But that's not, you know, that's like its whole own talk in itself. I'm going to talk about other ways that we can kind of address chronic pain. And the way that I do it is I use what I call the 3 M's. So movement and mobility, the mind-body connection, and medications. And I tell families that you need to be using all 3 to dial down that pain dial. So movement and mobility, what do I talk about when I talk to families about movement and mobility? I talk to them about daily movement, how important it is to move your body. And they might say, my leg is so painful, I can't move. Okay, don't move your leg, don't move your legs, but you can move your neck, or you can move your arms, or you can move something, even throwing a ball with your dog, or doing some gentle range of motion with your neck. Anything, any movement is better than no movement. And so we start with really small goals and try to increase from there. I, of course, always talk about trying to get in with physical therapy or aqua therapy. I'll sometimes recommend even a consultation with physical medicine physician, and talk about the importance of physical conditioning and muscle strengthening. I also talk about warm circulating water. You know, we know that warm water feels good for our patients with OI, and I talk to them about using it as a therapy, you know, not just using it and being like, oh yeah, the bath feels really good. No, think about it as therapy. You know, every night you're going to get into the hot tub, or you're going to get into the bathtub, and you're going to soak your body for 10 minutes, and that's going to be part of your plan. And then finally, within movement and mobility, it's really important to assess mobility device, access, and fitting. And I can't tell you how many times I've seen patients with OI whose mobility device is causing more pain. That's literally, of course, the opposite of what we want. And so making sure that their chair is fitting them properly, whatever mobility device they're using is the right size, the right height for them. They're not crouching over it, and that they have ideally access to a variety of different devices. I know difficult through insurance and everything, but we want them moving their body as much as possible. And it might be that there are certain activities that a walker is the perfect device and other activities where, a chair is the perfect device. And so having access to multiple mobility devices that fit them well can be really helpful. I, of course, always talk about the mind-body connection. This is kind of my third bucket. What I say to families is that there are multiple pain centers within the brain. And one of the pain centers is the amygdala, which is also our emotion center. So everyone who has pain has an emotional component to it. I also say, we know that our mind and our body are connected. Think about when you're going on stage and you get nervous and you get butterflies in your stomach. That is your mind talking to your body. It is not atypical, but actually typical to have your mind and your body talking. And so it's really important that we dial down the pain by dialing down the stress. It's very common for people to have stress about their pain. And it's also very common for people to have other stressors in their life that increase their pain. And and when I ask patients about that, they say, oh yeah, I have noticed that when I am stressed about XYZ, my pain goes up. I'm like, exactly. That's totally correct. That's expected, actually. But we need to figure out how to dial down the pain by dialing down the stress. And so I really recommend that patients with chronic pain find a therapist or what I call a pain coach to help them with coping strategies and coping mechanisms. I talk about strategies to preserve functioning, such as through cognitive behavioral therapy. And I also talk about ways that they can start working on some of this on their own. There are tons of amazing apps that someone can download on their phone to help them with kind of breathing exercises, self-hypnosis, guided imagery, meditation that they can do on their own. And what I tell families and patients is, do I think that self-hypnosis is going to decrease your pain to a zero? No, of course not. But what I'm suggesting is if you get home from a long day and you're having a ton of pain, you take whatever medication we've talked about, you're going to get into a warm bath. And while you're waiting for that medication and that warm bath to kick in, you're going to put on a guided imagery and kind of through the 10% Happier app, and you're going to listen to it and you're going to do some breathing exercises, and using all of those different modalities, your pain dial is going to go down from that 11 out of 10 to hopefully that 5 or 6 out of 10. That's our goal for you. And then lastly, I want to talk about pain medications. And these are kind of your general pain medications that are used in many different chronic pain conditions, but that I have found have been really helpful in some of our patients with chronic pain and OI. So, to start with low-hanging fruit here, of course, NSAIDs, and, I didn't even put in a slide for Tylenol or acetaminophen, but I do recommend as your kind of first line trialing your Tylenol and your NSAIDs. Certainly your Motrin and your Advil, but if I have a patient that's using Motrin or Advil on a daily basis, I'll sometimes rotate them to a long-acting NSAID like Aleve or Mobic that's only once or twice a day to kind of decrease their pill burden and also kind of to give them more coverage through the day or through the night whenever their pain is happening. I also will use NSAIDs to try to stop a pain cycle. So if someone is like, I am just having a ton of pain for the past 3 weeks, I might say, let's start Aleve, every 12 hours for 5 days to try to like break that pain cycle for you. And so sometimes I'll use that, as a modality. For our patients who are using Tylenol and Motrin to the max and are still having tons of pain, I certainly think about starting kind of a long-term chronic pain medication. the most common medicine that I reach for are the gabapentinoids. So gabapentin or Neurontin is what I typically will start with. I will usually do weight-based dosing unless someone is fully adult sized. But even, many of our adults, I'll do weight-based dosing for. And I find that many patients get started on gabapentin, but are put on kind of really like a whiff of a dose and not up titrated. Max dose that I typically go up to is 15 mg per kg per dose 3 times a day, or for adults, 900 milligrams 3 times a day. So I'll see people who are like, oh, I was on 100 milligrams at night and it didn't work. And I'm like, yeah, because that's a tiny dose. Now that's not to say I don't start at tiny doses. I find that a lot of our OI patients are very sensitive to medicines. And I don't want to scare them off by starting too high. So I will start maybe with 100 milligrams at night, and then I will slowly titrate over many weeks to whatever dosing that they need to decrease their pain to the functional status that they're hoping for. If I find that there is unwanted side effects or gabapentin isn't being well tolerated, I will sometimes rotate to pregabalin or Lyrica and see if that is better tolerated. The other medicine that I've had some nice response to are the SNRI, selective serotonin and norepinephrine reuptake inhibitors. Most commonly, I'll reach for Cymbalta or duloxetine. This is a medicine that is FDA approved for chronic pain, and for anxiety and depression, but is also approved for chronic pain. So for our patients who are reporting a lot of anxiety, worry, sadness, or depression because of and around their pain, I will typically reach for Cymbalta and see if this will help. I do tell patients that it's going to take 6 to 8 weeks to see the full effect. So we're going to have to give it time to see if it works. And I'll also start at a low dose and titrate up over a number of weeks. I do use it with caution in conjunction with NSAIDs because of the risk of both GI side effects and increased risk of bleeding. Tricyclic antidepressants can also be useful in chronic pain, especially if the gabapentin isn't fully working. There are studies that show that gabapentin plus a TCA together can have kind of a synergistic effect. The one thing I'll remind people of is that it can precipitate arrhythmias in those with pre-existing conditions. So it's recommended to get an EKG prior to starting. And of course, for our adults with OI who were already kind of monitoring their cardiac condition, making sure that they're up to date on that is important. I will also sometimes use an alpha agonist, specifically clonidine or guanfacine can also be used in this way. These alpha agonist medications are found to be helpful with chronic pain. They can also be helpful for sleep, and they can also be helpful for anxiety. They decrease blood pressure and heart rate. So for someone who's having vital sign changes because of their pain, having tachycardia and hypertension, this can be a really nice agent to try. And I love topicals. I know that that might sound funny because, these, people with OI aren't having kind of your topical or your like kind of on the surface pain, but I have had some good results with topical agents. So, and I think you might as well try them, especially for someone who is hesitant to use medications or is using a lot of Motrin or Tylenol, but doesn't want to take on a daily pain medicine, but wants another like as needed medicine. I'll try a topical. I'll try topical lidocaine or lidocaine patches. A lot of patients swear by Icy Hot, which is an NSAID, or diclofenac Voltaren gel, which is an NSAID, and just rubbing it on the areas that are painful. I will also sometimes use capsaicin, which is the active component in chili pepper. I find that teenagers find it kind of don't find it helpful. They find it like a weird feeling and they don't like it. But adults adults do tend to find it helpful. And then I want to talk about herbal remedies briefly. So especially for those that are like, I want a natural remedy, or something that's a little bit more gentle. These are over-the-counter herbal remedies that have been studied and found to be helpful, especially in other dysplasias. But I have kind of extrapolated and used in some of our chronic OI patients and had good results. So curcumin, which is the active component in turmeric, is a spice with anti-inflammatory properties, pain relief comparable to NSAIDs. And there are some recommended dosages based on a couple of studies. And then resveratrol, which is a natural component found in red wine and grapes, is an anti-inflammatory and antioxidant. It's also an antihypertensive and antiplatelet aggregate. So just be careful in those that are already on blood pressure medicines or on a, any kind of blood thinner for any reason. But again, those are recommended doses based on a couple of studies in other dysplasias. And then medical marijuana, which is a common question that comes up for patients with chronic pain. I'm not opposed to medical marijuana. I do not recommend it in the developing brain. It has been found to affect the developing brain in negative ways. So for those under the age of 25, I don't recommend it. But for young adults and adults with chronic pain, there are some studies that show that it can help with pain and with sleep. But also it can worsen anxiety. I know some people use medical marijuana and think it helps with their anxiety, but it typically kind of makes that up and down effect. And so I don't recommend it for people that have a lot of anxiety with their pain. I recommend limiting the THC component as much as possible and to start low and go slow. So start at the lowest dose and kind of up titrate really slowly with it. And I took out my slide about opioids, which I will just say briefly. Opioids, of course, we use a lot in patients with OI in the setting of fracture surgery. In general, I don't recommend it for people who are having chronic pain. Although I find many patients with chronic pain and OI are on lots of opioids, I typically recommend that we wean off of them because of the hyperalgesic effect, effects that it can possibly have on bone density and increasing fractures due to dizziness and, difficulty walking or waking up in the middle of the night, those kind of things. And so I'll typically wean off of opioids while starting some of these other chronic pain medicines. And then briefly on caring for infants with OI, pain management is incredibly important and life-saving in the first couple of weeks following delivery. So many babies will sustain fractures in utero or following delivery, and then we'll have apnea events, breath holding spells, and difficulty breathing due to the pain. And so we recommend good pain management in the first couple of weeks with opioids and with opioid infusions as needed, clustering cares as much as possible, allowing the body to heal. Recommend don't overfeed babies with OI, and early bisphosphonates are extremely helpful. We try to get bisphosphonates in by 2 weeks of life, as long as the baby is getting full feeds and is stable from a respiratory perspective. And that is all I got. I guess I deleted my my thank you slide, so I apologize for that, but I want to thank and acknowledge all of my Nemours team who kind of are part of my multidisciplinary team caring for these patients with OI.
Ricky, that was terrific.
Thank
Thank
you.
you very much. For those of us who don't have a you, because your strategy is, I think, very, very thoughtful, and I'm becoming more and more aware of just how erosive the chronic pain can be. Do you have some good handouts or things that you can share on that?
So, one of my genetic counselors and I did put together a handout for patients that I'm happy to share with providers. it's kind of like we made it on our own. It's not very like formal, but it does go through some of this. It doesn't have medication recommendations on it, as you can imagine, but it kind of talks about the other M's. Like it talks about thinking about, one of the other things I talk to families about that I didn't talk about here is like thinking about what your pain is, keeping a pain diary and trying to describe it, except especially for our children with pain, trying to help them describe what they're feeling. Is it muscle fatigue? Is it muscle cramping? Is it nerve pain? Is it shooting pain? Is it throbbing? Like helping describe it is very helpful to figure out how to help them. And so the worksheet kind of goes through ways to help someone think about their pain, ways to think about mobility. And then it has 2 pages of different apps on your phone that you can download for the mind-body connection and kind of decreasing stress around your pain. I'm happy to share it with
I
anyone.
really appreciated that concept of dialing it down. That's a kid can really, I think, grab on to that, whereas some of the other things that we say to kids don't always compute with them, but working with their parents to help them work with the child to dial it down just makes tremendous sense.
It's just that idea that like we're not going to get their pain to 0, right? But when you tell families that, like, listen, we're not going to completely fix your pain, that can be very disheartening. And so if you talk about the pain dial, you don't really have to say that. You just say like, I know you have pain, and we're going to try to dial it down with them. And the other thing is like people hope like that there's one magic bullet, that like they can take one pill or do one thing. And that's also not the case. So we're going to dial down the pain as much as we can. I'll say like, when you're feeling good, when you're having a great day, where is your pain? And they might say my pain's a 4. And I'll say, perfect. Then we're going to aim to get your pain dial to a 4. And we're going to do it with multiple different modalities. So we're going to use self-hypnosis every night, and that's going to bring your pain down from a 9 to an 8. And we're going to use, I don't know, Mobec every day, and that's going to dial your pain down from an 8 to a 6. And we're going to do this and that. And physical therapy is going to slowly dial your pain down to that 4 over time. And so.
Fabulous. Well, and I had not realized you're in Europe. How exciting for us. And I hope we haven't kept you up way too late. But thank you so much for contributing. We are at the end of our time, but I want to be sure I'm not hogging if anybody else has a question. And thank you everyone for participating with us tonight. I wish everyone great holidays, a happy new year, and we'll do this again in the spring because there's so much to share. Thank you all for being with us tonight.